Hello everybody. Welcome to our YouTube channel No1doctor. Today we have a medical discussion with one of the famous surgeon in the world. We will talk about one of the common surgical problems. Welcome, doctor.
Welcome to you and to your channel subscribers.
Doctor. A 30-year female patient presented with acute pain in right lower quadrant of abdomen. How will you proceed to manage?
Important causes of pain in the right lower quadrant of abdomen are acute appendicitis, acute typhlitis, Mrcs diverticulitis, right-sided disturbed ectopic pregnancy, acute salpingitis, twisted right ovarian cyst, acute intestinal obstruction, ileocecal tuberculosis, acute Crohn's ileitis, perforated peptic ulcer, acute cholecystitis, acute pancreatitis, ureteric colic, acute pyelonephritis, So's abscess. For proper management, detailed history, physical examination, and some relevant investigations are required. In acute appendicitis, classically pain starts around the umbilicus and shifts to the right iliac fossa. There is associated nausea, vomiting and fever. Patient may have loss of appetite. In female patient, exclude gynecological causes of pain, menstrual history, any bleeding per vagina. On examination, the patient may have features of sepsis and shock. Patient may be febrile. Tenderness at McBurney's point. There may be positive Roffsing's sign, So's sign, and rebound tenderness may be present. If appendix is perforated, there may be generalized guarding and rigidity in abdomen.
Doctor. Which investigations are helpful for diagnosis of acute appendicitis?
Hemogram, polymorphonuclear leukocytosis. Urine for routine examination, presence of pus cells and protein in urine, may be due to bladder irritation caused by a pelvic appendix or may indicate urinary tract infection. C-reactive protein may be elevated. Ultrasonography, sensitivity of 86% and specificity of 81% for diagnosis of acute appendicitis. CT scan of abdomen, sensitivity of 94% and specificity of 95% for diagnosis of acute appendicitis. In women of childbearing age, urine for beta-HCG to exclude ectopic pregnancy. Acute appendicitis, emergency appendisectomy is the standard of care for acute appendicitis. Initial treatment, nothing by mouth. Intravenous fluid. Broad-spectrum antibiotics, second-generation cephalosporin or aminoglycoside and metronidazole. Analgesic. Emergency appendisectomy. The operation should preferably done within 24 hours of admission. The risk of perforation increases with time. After 36 hours, the risk of perforation is 16 to 36%, and the risk increases by 5% for every 12 hours passed. In Mrcs diverticulitis, Mrcelian diverticulectomy with a wedge of the ileum. In acute intestinal obstruction, conservative treatment, nothing by mouth. Nasogastric aspiration. Intravenous fluid resuscitation. Antibiotics. Monitoring. Indications of surgery, failure of conservative treatment. Symptoms and signs of strangulation. Diagnosis uncertain. Ureteric colic, analgesics for pain relief. Injection of diclofenac sodium may relieve the pain. Small stones less than 1 centimeter may pass out spontaneously. Stones greater than 1 centimeter unlikely to pass spontaneously. Usmle or PCNL or open surgery for removal of stone. Acute pyelonephritis, analgesics. Antibiotics. Empiric antibiotic therapy followed by appropriate antibiotic depending on culture sensitivity of urine. Treatment of any underlying cause, stone or stricture. Ectopic pregnancy, resuscitation. Emergency laparotomy or laparoscopy and salpingectomy along with removal of the product of conceptus.
Doctor. What should be the preferred technique for appendisectomy?
Currently there has been debate regarding advantage of laparoscopic technique over open technique. In laparoscopic technique there is less post-operative pain, better cosmetic result, and less post-operative wound infection. This is particularly useful when there is doubt in diagnosis.
Doctor, what should be the strategy when a normal appendix is found during operation?
When a normal appendix is found during either open or laparoscopic operation, the recommendation is to remove the normal appendix to avoid diagnostic confusion in future. There has been some studies where the normal appendix was not removed. In follow-up, 4 to 13% of such patients required appendisectomy for recurrent abdominal pain. In one series 58% of normal-looking appendix shows histological features of inflammation. These studies suggest that the normal-looking appendix during operation should be removed.
Thanks, doctor, for this excellent discussion. Hope to see you again in more medical discussions. With my best wishes. Dr. Atfamid.